This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, it's Jeff Ratliff with Thomas Jefferson University and the Neurology podcast. I'm here with John Winkelman from Massachusetts General Hospital in Boston. John's the first author of a collaborative article published in the Journal of Clinical Sleep Medicine online in January of 2025 titled Treatment of Restless Leg Syndrome and Periodic Limb Movement Disorder, an American Academy of Sleep Medicine Clinical Practice Guideline. This guideline represents the work of a commissioned task force of restless leg syndrome experts who systematically reviewed and evaluated the literature on RLS treatment to derive a series of updated recommendations. We invited John here to discuss these guidelines and to walk our listeners through some practical advice for clinicians who do take care of patients with restless leg syndrome. John, welcome to the podcast.
Thank you, Jeff.
So before we get into the conversation on management and treatment of RLS, I do think it's important for us to quickly review clinical definitions and diagnosis. And I'll quote from the paper where you and your authors defined restless leg syndrome as a sleep-related movement disorder characterized by a, quote, urge to move one or both legs and sometimes the arms when immobile, which is relieved by movement and is most prominent in the evening or at night. I think many of our clinician listeners can recognize that classic phenotype of restless leg, but what advice do you have for our listeners to help them ensure that they're accurately making a restless leg diagnosis while also avoiding some more common mimics of restless leg?
We need to remember that diagnostically, there is a quick way for you and your patients to know what restless legs is the acronym URGE. An urge or need to move the legs that's present at rest, as Jeff suggested. Important to do the G, that gets better with movement and is predominantly present in the evening or at night. Now, some people can have these sensory mimics, these achy, creepy, crawly feelings that are oftentimes present in restless leg syndrome and not have RLS. For instance, some kind of neuropathies can have pain in the lower legs, tingling certainly, but the main distinction there is those usually do not improve with movement. The G gets better with movement. There are going to be some people who have anxiety or ADHD or are bouncing their legs a lot. If you ask them, do you have to move your legs? Do you have a need to move your legs? They're not really going to report that. They won't report the circadian rhythm. Finally, the thing to distinguish on the motor side is periodic leg movements of sleep on a sleep study are not RLS. Almost all people with RLS will have periodic leg movements on polysomnography, but there are many, many more people who have frequent leg movements even on PSG who don't have RLS.
I think that's really helpful and cements that diagnostic mnemonic that you outlined, I think is really useful. One of the big take-home points of these guidelines is a shift further away from recommending certain therapies and specifically looking at dopamine replacement or dopamine agonizing therapies. And the paper cites specifically that this is a means of avoiding this phenomenon called augmentation. Before we jump into the guidelines themselves, can you briefly tell us what is augmentation when we're talking about restless leg syndrome?
Augmentation is an iatrogenic worsening of RLS due to dopaminergics, either levodopa or the dopamine agonists. Augmentation generally occurs over a period of years, manifested by an earlier and earlier onset of RLS symptoms. They originally started at 10 o'clock, so you give the medicine at 9. After a year or two, now they're starting at 7 o'clock, so you say split the dose, take it at 6, and take some more at 10. Now, a couple years later, now they're starting at 4 o'clock, blah, blah, blah. And not only do you get this temporal expansion, but you get an anatomic expansion. Many people start experiencing symptoms in their upper extremities, which are very, very bothersome because they're much harder to get rid of. Just standing up and walking around doesn't do it. And in general, people just have an overall worsening of symptoms. It's really important to recognize that dopaminergic agents work fantastically over the short term. I call this the honeymoon period. But don't be fooled the way I was. I was the first author on the pivotal trial for FDA approval of pramipexole. Worked great. Published in Neurology. I was very proud. 2006, 12-week trial. As I discovered, treating people with these medications over many, many years, and as most providers themselves have learned, over the long term, most people given a dopaminergic agent will experience this augmentation, this iatrogenic worsening of symptoms.
That's really helpful. And so now that we have that background to hopefully allow listeners to recognize restless leg syndrome, but also to recognize when this augmentation phenomenon is occurring, let's jump into some clinical scenarios and try and see how the guideline would guide us in those situations. And so let's imagine our listeners are seeing a patient in the clinic who is totally naive to any treatment, but they've made a diagnosis of restless leg syndrome. Perhaps before they go order a new prescription, a new medication, what do the guidelines recommend we do with regards to identifying any exacerbating or aggravating factors that may be driving their restless leg symptoms?
Before prescribing anything, we want to try to understand what could be causing it in the first place. And for many people, we can identify reversible factors that can improve symptom severity. And the main ones we want to think about are iron status and variety of medications and some comorbid disorders, particularly sleep apnea. So let's cover each one of those. Our main understanding of the pathophysiology of restless leg syndrome are two things. One, strong genetic influence. Can't really do much about that. And two, central nervous system iron deficiency. Hard to measure CNS iron, except in research protocols. However, we can measure peripheral iron status. And so we always want to get three things when we order iron studies. And no one with RLS should leave your office without a requisition for iron studies. And those are ferritin, iron, and TIBC. We get all three because each one of them can be confounded by various things. So make sure you get all three of those. Second, serotonergic reuptake inhibitors, very commonly prescribed, oftentimes worsen restless leg syndrome. Similarly, antihistamines, centrally acting ones, whether that be, diphenhydramine or whether it be mirtazapine or hydroxyzine. A lot of medicines have antihistamine properties and they're going to worsen RLS. And the third class of medicines I would think about are the dopamine antagonists that worsen RLS, whether they're CNS-oriented medicines or even something like Reglan, which would be peripheral focus. And finally, sleep apnea. The problem is it's really hard to treat sleep apnea with CPAP when people have bad RLS. They can't use CPAP because they're flipping and flopping too much. So the low-hanging fruit there is try to treat the RLS and then treat the OSA.
I think those are all really helpful. And before we get into the iron, just reviewing that, looking at the medication list, looking for some of those common offenders, the antihistamines, the dopamine blocking agents if they're there, the serotonergic drugs if they're there, and then also keeping an eye out for comorbid sleep apnea and thinking about putting the restless leg treatment at the top of the list before you go trying to get someone set up for CPAP. So given that, let's talk more about iron supplementation replacement. So you mentioned the key labs that we should be sending our patients out to have checked is a ferritin, a serum iron, and a TIBC. And so I'm hoping you can help guide on two things. One, what values on those lab tests should we be looking out for, or maybe some key cutoff values that are going to dictate how we treat the patient. And then when we do decide that iron supplementation is necessary, how do we go about doing that?
Right. Well, I think it's important to recognize we are using serum iron indices as some kind of proxy for brain iron, but it's a poor proxy. And for that reason, and based upon the clinical trials that have been done with oral and IV iron, we use thresholds that are different than you might use in your ordinary practice. So we say any ferritin below 100 any transferrin saturation, which is iron divided by TIBC, below 20% warrants some kind of iron treatment. Before you send your patients for iron indices, make sure to tell them no red meat, no iron-containing vitamins for 48 hours before the morning blood test. I say to people, Mrs. Smith, I want your iron levels. I do not want a hamburger level. And so that way they may remember it, because that's an important confound for iron. Ferritin obviously is a acute phase reactant, so goes up in a variety of contexts. If the ferritin or iron in TSAT come below those thresholds, we're going to recommend intervention. Problem with oral iron, besides the GI side effects that people have, is it's very poorly absorbed if your ferritin is above 50. And so that means in the range of 50 to 100 of ferritin, you can take iron all you want, but most of it's going to end up in the toilet. So I'd say to people, I'm not sure that's the way to go. So for those people and for people who don't tolerate oral iron, we use IV iron. And we have a number of specific iron formulations that we recommend. The task force recommended in the guidelines, which are well tolerated. Really, we just about never see the anaphylaxis that we had with the old-fashioned IV iron. It's usually extremely well tolerated. Important to write down when you're ordering IV iron, don't put as the indication RLS, because it'll bounce back. Put iron deficiency or disorder of iron metabolism, because I feel fully comfortable doing that. RLS is a brain iron deficiency. So if you put iron deficiency, I've rarely had problems with insurance coverage in that context.
And when we're talking about IV iron, can you mention those specific formulations that were in the guidelines?
Our first line medication was ferric carboxymaltose, which you can give in either 1 or 2 infusions. We try to get 1,000 milligrams of iron in. And really, for most people, unless they're actively losing blood, it's one and done. Once you get 1,000 milligrams, you're fine. I also will use ferraheme, ferrimoxetol, which requires 2 infusions roughly a week apart of about 500 milligrams each time. I give a lot of IV iron. About a third of people will do really well with it. 2/3 say,
Nothing in regards to they don't feel that the restless leg symptoms improve much. Okay.
Exactly. Some people actually get a little boost in energy, but no, about 2/3 won't find substantial benefit.
Okay. So let's talk about those 2/3. You've checked your iron levels, you've prescribed and hopefully adequately replaced any iron deficiency that's going on. And these patients come back and say, I'm still struggling with symptoms. I still have this uncomfortable sensation after dinner, and I got to pace around, and it's hard for me to sleep, and all of the symptoms and bothers that this syndrome can cause. And so now perhaps it's time to pull out my old prescription pad or log into our EMR and write a prescription. And so when we're talking about initial pharmacologic therapy beyond iron supplementation, what did the guidelines here recommend that we should be going to first for these patients?
Well, the task force strongly recommended 2 different approaches. We've talked about iron as one of them. The other approach would be the alpha-2 delta calcium channel ligands, which are gabapentin, pregabalin, and gabapentin N-acarbonyl. All 3 have very strong clinical trial evidence in RCTs for their efficacy in restless leg syndrome. We published, I have to say, a really nice study of pregabalin versus placebo and versus a dopamine agonist, published in 2014 in the New England Journal. Long outcomes, and pregabalin at 300 milligrams was as efficacious as the dopamine agonist, actually a little bit even more so, and certainly more than placebo, maintained for at least a year. However, these medicines, as we all know, can have side effects, and tolerability becomes an issue for some people. So warn about side effects beforehand. Start low, go slow. It's not an emergency usually. Tell people I'd rather go slowly and get you to an effective dose rather than rush. And in my hands, the majority of people are able to tolerate efficacious doses.
Just to follow up on some of that tolerability and maybe thinking about a plan B or a plan C, let's say a gabapentin and a carbil, you've followed those instructions, you're building up slowly, you're still running into a tolerability issue. Do you still tend to try within those triad of medicines that you just mentioned, pregabalin, other gabapentin formulations, do you try those out before we go switch over to a new drug class or try a different strategy?
If I've started with gabapentin and a carbil, yes, because it is a controlled release formulation. So whatever dose you're giving it over the 24 hours. For many of your patients, you don't really need it over the 24 hours. So you may be shortchanging the evening and nighttime period in favor of treating the daytime period. So in that case, and because insurance may fight you on getting to an adequate dose, I will try pregabalin or gabapentin if that is not effective. Important to recognize, and pharma never told us this, that gabapentin has nonlinear pharmacokinetics. So above 600 milligrams at a single dose of gabapentin, there's really erratic and poor absorption. So if you want to get a good serum concentration of gabapentin, you have to split the dose. And if you want to focus on the evening, you may have to split it to 600 at 6, 600 at 8, 600 at 10. That's difficult in terms of adherence. Pregabalin has linear pharmacokinetics. So you can give all of your dose all at once, maybe at 8 o'clock, and get all of it absorbed. What you give is what you get. That's not true with gabapentin.
That's really helpful. And so reach for the pregabalin or gabapentin-derived medications as our first line. And as we discussed before, these guidelines really largely recommend against the use of levodopa or dopamine agonist medications, given those risks of augmentation that we talked about. And listeners are likely familiar with other risks of dopamine agonizing therapies like impulse control disorders and other things there. That said, I think there's plenty of patients who are out there who are currently taking and being prescribed these dopamine-focused medications for their restless leg. And so when those patients are coming into the office, perhaps for a second or third opinion, what's the approach? Should we be actively trying to wean these medications off? How do we recommend we help patients who are currently on these meds that the guidelines are recommending we not use?
Yeah, that's a great question. It's one that was really not addressed by the task force. But I'll give you my opinion here. And in the end, we're not the one as providers taking these medications. In the end, this is patient choice. And so we collaborate with them in making a decision. But people on dopamine agonists can kind of be divided into two groups, those without current augmentation and those with augmentation. So let's handle them one at a time. Those without augmentation, we educate. We say the majority of people on these dopamine agonists over many years, and many people with RLS are going to be on these medicines 20, 30 years. RLS isn't going to go away. It's a chronic medical problem requiring chronic solutions over many years will develop some degree of augmentation. And so you need to let them know what those symptoms are. Earlier appearance of RLS, going up to the arms, more severe, reduced duration of benefit of the dopamine agonist. It used to last all night. Now it poops out at 3 a.m. Educate, 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 and make sure you see them at least every 6 months and ask them about augmentation symptoms. In those with augmentation, you say, look, this medicine was great for a while. You fell in love with it. It got rid of your RLS like that. But now you're in an abusive relationship. And what my opinion would be, I would say to somebody, is before this gets worse, because this will probably evolve and get worse and worse and worse, our goal will be to eventually discontinue the dopamine agonist. And people gasp, although at the same time they know that they've had to increase the dose, take it multiple times a day. They know that there's a problem. And so they are on board basically with you. And so eventually we're going to have to discontinue to get down to a much lower dose. How do we do that? And we say, I'm going to add on the medication which I think will eventually replace the dopamine agonist, add first before subtracting, up titrating that medication to an effective and tolerable dose. And then we're going to very gradually detox you from the dopamine agonist. And I use that word not lightly. And so I would say usually I aim for stopping the dopamine agonist over a period of 6 to 12 months, about 10% a month. The first week, when you reduce the dose even by a wee bit, symptoms flare up, and you tell them symptoms are going to flare up that first week. After the first week or so, you're going to go back to normal, but you're going to be on less medicine. And we'll keep doing that every month until you're off.
I think that's helpful, and I appreciate you being so specific with that chronology and the timing of how we do that.
The main reason people fail is because they try to go too fast.
Yeah.
They know it's a problem, and so they say, I'm just going to do it. And then a couple of weeks later, they say, couldn't do it, was up for 5 days without any sleep, walking the floors. I fell twice. I was walking around outside in my driveway. And then you say, okay, let's try it my way now, slow and steady.
Yeah. The last topic I want to touch on is a third class or family of medications. And we are both familiar with the ongoing epidemic of opioid addiction going on both here in the United States and abroad. We also know that opioid medications can have a therapeutic utility in restless leg syndrome. And so I'm hoping you could summarize for us what the task force and this guideline document tells us about how and when to use an opioid-derived medication when it comes to patients with restless leg syndrome.
It's been recognized that opioids have worked for restless leg syndrome for hundreds of years. The earliest descriptions of RLS talked about opioid medicines as treatment. And I want to emphasize that we use them in extremely low doses. They should only be attempted, in my feeling, if other approaches are not working. Particularly, we use them in patients with augmentation where the alpha-2 delta agents, gabapentin, pregabalin, gabapentin, and acarbol, are not tolerated or not effective in treating symptoms. Iron hasn't worked. We've done whatever we can do to the underlying causes. At that point, we add on an opioid medication and get it to effective doses. I'll talk about those in a minute. And then gradually taper the dopamine agonists. So what are the medications that we use? Generally, in augmented patients, they've got symptoms 12 hours a day, okay? So from maybe 4 p.m. till 4 a.m., they are vulnerable to symptoms, they're not sleeping, etc. So the encouragement is to use long-acting agents. Rather than using oxycodone, which lasts 4 hours, and having people pop oxycodones every 4 hours, which I think is really a mistake, we use long-acting agents. And mostly we use either methadone or buprenorphine formulations. Now, again, we're using about dose-wise 10% of what is used in patients with chronic pain or patients with opioid use disorder. So for methadone, the average dose is about 10 milligrams. For opioid use disorder, it's generally over 100 milligrams. For buprenorphine, it's anywhere from a few hundred micrograms, maybe to 1 or 2 milligrams. The smallest Suboxone dose is 2 milligrams. So you have to cut the film into quarters or break the pill into quarters to get that dose. Very low doses of a long-acting medication. There's now quite good long-term data showing that people use these medications extremely responsibly and stay at a relatively stable dose for long periods of time. So people will say, aren't you worried that people are going to get addicted to it? And I say, I don't really even know what addiction means in this context. We're treating a chronic problem with a solution. But if they're addicted to anything, it's the dopaminergic agent, which has made the underlying problem worse. If you skip even half of one dose, symptoms are terribly increased, and people need to take it earlier and earlier and earlier during the day, multiple times a day. That's the medication that I'm worried about addiction. Opioids need to be prescribed very carefully. You need to assess their risk for misuse and abuse. You need to check the PDMP. You need to see them every 3 to 4 months. I'm checking. I have not had problems with people misusing these, but I'm all over it. But I have many, 100 people on long-acting opioids. It's unusual for me to prescribe a short-acting opioid, which has efficacy, and then when it wears off, rebound. And I don't want to deal with any rebound.
Yeah, absolutely. And just to be clear, augmentation is not something we would expect with opioid therapy. It's really just with the dopaminergic therapies.
No, I have a long-term national registry, 500 patients around the U.S. We've been looking at doses every 6 months, checking PDMPs in states all over the country. People are at very stable doses. So again, addiction, yes, they need to take the medication, but they've got, people with diabetes need to take insulin. People with PD need to take a dopaminergic. We're treating the problem, but they don't misuse and they don't escalate their dose dramatically. But you're checking that very regularly.
Perfect. And in wrapping us up, I want to talk a little bit about what you and your co-author said in the discussion of this article. And so in that discussion, you note that experts like yourself have been publishing and recommending that we move away from dopamine agonists as a first-line therapy in RLS for about a decade now. But in the real world, the shift in clinical practice has not sort of rapidly integrated those recommendations. And so if we can take an optimistic view, and let's say that the guideline that we're talking about today is going to get to the eyes of clinicians who are caring for patients with restless leg, that this podcast will be the most listened to episode we've ever had. We're going to get the word out there. What does the clinical landscape of restless leg management look like in another 10 years? What are the shifts in practice you think are the main take-home points from these guidelines that we hope will sort of be integrated as we move forward in the coming years?
I'm not so good at looking at the future. I'm really much better at looking at the past. I can tell you, we did a drug utilization study a few years ago using IQVIA data. It's basically every doctor in the United States and their prescriptions, looking at the doses of dopamine agonists. 2/3 of people with RLS are taking a dopamine agonist. 20% of them are taking a dopamine agonist that is being prescribed at above FDA maximum recommended for RLS. And the specialty that is most guilty of that, I bet you can guess, are neurologists, because they're comfortable prescribing dopamine agonists at high doses for PD. But RLS is not PD. You get to those higher doses, Prami above 0.5, Rapinirole above 4 milligrams, there's something wrong. Something's gone really wrong. And so I would hope that neurologists would hear this and look at their patients and recognize that patients are augmenting. They're going to stop prescribing this as first-line treatment to their patients. They're going to look and see that they have patients have augmentation. They'll ask questions about that, and they'll follow these recommendations. Add the second medication, probably an alpha-2 delta, look at iron and other things, and then very, very gradually wean off the dopamine agonist. It takes a fair number of visits and some intermittent contact. These are not people you can say, I'll see you in 6 months. That's how you want to practice. You should really refer them out to sleep medicine, because it's not going to work that well unless you have people who can really follow a regimen of every month, they reduce it by 10%. They need a little more hand-holding. They may need some adjustments over time. Hopefully primary care, which is the vast majority of prescribers in the U.S., will hear about this and will recognize that not to use dopamine agonists, even though they're so lovely in the short term. And I would recommend, we have a nonprofit funded website that we just started in the last year, rlscurbside.org, rlscurbside.org. Only open to providers, not for patients. You have to show your medical license to get access, but we have a beautiful website, if I have to say so, and it's formatted like a Reddit forum, and you type in information about your patient, and then a variety of experts responds saying, oh, in that case, I would try this or try that, or that's interesting. Maybe you want to do this, that, and the other thing. And so it's a peer-to-peer resource, which I think will hopefully get more and more used. It's already got a lot of use just in this last year, but I think it'll become increasingly valuable.
I think all of that sounds great. And hopefully, as you said, neurologists may be comfortable with prescribing high doses of dopamine agonists in other contexts, but hopefully they also have that familiarity with prescribing gabapentin and pregabalin in other contexts as well. So these practices and these guidelines that you walked us through shouldn't be insurmountable, and hopefully we can see the needle move on getting the proper therapy to these patients. I've been speaking with John Winkelman from Massachusetts General Hospital about a paper he and a number of RLS experts authored titled Treatment of Restless Leg Syndrome and Periodic Limb Movement Disorder, an American Academy of Sleep Medicine Clinical Practice Guideline, and that was published online in the Journal of Clinical Sleep Medicine in January. John, thanks for joining us, and thanks for the education today.
My great pleasure. The article is open access, so you can get full text.
Perfect. Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.